Start out talking about the state single-payer meeting that was held on Friday for 3 hours at a hotel a block or two from the Maine hotel where the PNHP meeting was. There were 23 people from 13 states who attended this meeting. Steve Kimball talked about Hawaii. He's a PNHP board advisor and past president of the Hawaii Medical Society. In 2009, the Hawaii Health Authority was created, and it was a generous plan that was approved over the veto of the then Republican governor. It it basically is meant to cover everybody and anyone working 20 hours a week to get health insurance under Hawaii's employee mandate got covered, but businesses basically, according to Steve, increasingly hiring part-time to avoid the 20-hour the employer had to cover them. Okay, when the Affordable Act came around, political leaders in Hawaii kind of shifted away from the single payer that they were pushing. The governor there moved to the ACA and ACOs. The current governor, David Ng, listened to his health commissioner who resigned 6 months ago, but Governor Ng's doctor is a friend of Steve Kimball's and would like to work on him to support single payer. And there's a possibility that he might be the next health commissioner. Steve believes that state and national strategies can be complementary. Interest in single payers increased noticeably following Bernie Sanders' campaign in 2016. And he stresses the value of social media and networking that was evident in Bernie's campaign, and that youth are pushing for progressive causes, including single payer now. Maine, Phil Caper was there, and he was a staff member of Ted Kennedy when Kennedy was working on his health plan. Maine All Care is a bill that they've been pushing there for 10 years or so. Maine All Care is also an organization that has a website, mainehealthcare.org. It has a statement of principles, publicly funded, comprehensive, affordable, provider-directed, public good over public profit, and so on, everyone in the same system. Basically, they use their legislation for educational purposes, have a full-time staffer, and put out a newsletter once a month. Maine has 1.3 million population, and they have 50,000 supporters on their mailing list. They've gotten big donations from Stephen King, the novelist who lives there, as well as other individual donated money and support. And they set up tables at polling places and other places and ask about what people feel about health care. 70% seem to be in support of universal health care, 30% didn't support it. Goal is to educate the public till a tipping point is reached. Their organizing method, they go to Rotary clubs, house parties, and so on. Minnesota, a guy named Ken Jocelyn, this semi-retired physician, was there. He teaches residents at the University of Minnesota. Minnesota has a 10-year idealistic single-payer bill. He says the Minnesota movement has been active but not very aggressive. 7 or 8 years ago, there was a coalition for single payer, but then the Affordable Care Act sucked all the energy out of that movement. A lot of places around the country experienced that with the onset when the Affordable Care Act was implemented. John Guyman from Washington State, PNHP chapter, was there, talked a little bit. Sherry Weinberg, sitting at the table here, was there and talked about Washington.
Mostly I talked about the fact that we've got a very excited Nicole Macri, who's a Democratic representative in our state House of Representatives, who is trying to put in place a bill that could actually pass without any federal help, which means it could only cover a limited population, but she wants to put in some of, and we want her to, put in some of the administrative steps, particularly the 3 advisory committees, citizens, financial, and technical, that would bring in a lot of people to start laying the groundwork for what could eventually become a publicly funded, publicly run coverage system covering everybody in our state.
So I talked a little bit about the history of our chapter here. Been around for 13 years, and with monthly meetings, and only having missed 2 or 3 months during that 13-year period. We usually have an outside speaker, but sometimes, like today, we talk about other things of importance locally and here nationally, what happened at the national meeting. We've started live streaming 3 or 4 months ago. 6 or 7 years ago, I talked about how we were instrumental in starting the Healthcare as a Human Right Coalition, got the original 15 organizations together, and then basically that has morphed into a much larger organization now, pretty much under the control of the Washington State Labor Council folks, Washington Community Action Network, and other people, but the goal still is single payer. Everybody agrees the national level is the solution, but they're focusing a lot on what's going on in the legislature in Washington State to try to get everybody covered. I talked a little bit about our meeting with Representative Jayapal. 3 of the people here tonight were there, and a couple other people. We had a nice half-hour meeting with her, and we're trying to feel her out about her plans for the new House Medicare for All caucus. And we let her know that we were against leaving for-profits in there, which are in Bernie's bill, and the pay for performance, which is in Medicare, and it seems to be in Bernie's bill too. And I think she heard us, and I think she agrees with us. In fact, she met with Adam Gaffney, and he talked about those things. And at the annual meeting, I also ran into Bonnie Castillo, who's the new executive director of the National Nurses United, who is a powerful national organization with a lot of money and has a lot of influence on politicians. And she says she's definitely against for-profit providers remaining in the new Medicare for All. Well, Pramila's going to be the main sponsor of H.R. 676, and she told us and other people that she'd like to see the 2 bills, the House and Senate bills, come closer together. And when we talked to her, she said Bernie wasn't willing to change anything in his bill, and she thought he was probably just waiting to see what kind of pressure and influence the House caucus was going to generate. Apparently, recently, Himmelhandler and some other folks in Washington have met with Bernie's staff, and it seems like he's going to be willing to make some concessions there. As he did when he took out the co-pays, which he had in the original bill. He had co-pays for most of the services, but after a lot of pressure, he took those out except for a small co-pay on some drugs. So I think what eventually is introduced in the Congress in January, the new H.R. 676 is going to be unveiled then. Pramila's idea is she'd like to have it introduced into the congressional committees that are important, with the idea of hopefully getting a floor vote sometime in 2019 or possibly 2020. I should say that there's a lot of suspicion about what's going on behind the curtains there, so I have a lot of faith in Pramila, so I'm hoping with fingers crossed that we're going to see a pretty strong H.R. 676 that we can all get behind. Mike Huntington and Paul Hochfeld from Oregon talked about what's going on in Oregon. They've had some single-payer bills introduced there and some studies done to look at what a single-payer bill would do to the finances in Oregon. Their single-payer bill has been introduced every year or every biennium since 2011. They were not expected to get out of committee, but were used for a tool for education and organizing the public regarding universal health care. The RAND study that was done in 2016 showed that Oregon could have a universal risk pool publicly funded and would cost no more than Oregon residents are spending now for their health care without any premiums, co-pays or deductibles or other out-of-pocket expenses. Paul Hochfeld, who's a board member and one of the founders of the Matters Health Doctors, if you remember them from a few years ago, he's very suspicious and believes the feds will sabotage states at the national level if the states get any momentum going. He believes that the first state that does single payer has to do it really right or it will permanently cripple the movement. He wonders if the western states could get a consortium together for a West Coast plan. California, there's quite a number of people from California there. But basically, they were all involved in the universal quasi-single-payer bill that was moved through, I think, one of their, the House. The history there is that they had a bill that Sheila Kuhl put together that was passed in both houses a couple of times, but vetoed by Arnold Schwarzenegger when he was governor. Bernie Sanders reignited the single-payer interest in Californian enthusiasm. And if they passed the bill, which passed one of the houses and was not voted on in the other chamber because the senator who controlled the committee refused to introduce it, Gavin Newsom, who was elected governor, said that he would support single payer when he was campaigning, and he's kind of, people think he's backing off a little bit about that. So, you know, when he takes office, they're all getting together to push him. From California, we had several members of, there's I think 8 or 9 PNHP chapters in California, and under the umbrella of the California PNHP, somebody from the California Teachers Association, Bill Honigman, you know him, Dr. Bill from PDA, he's one of the co-founders of the PDA. You probably get emails from him, he was there. And he believes that we can walk and chew gum at the same time, i.e. support single payer at the state and national levels. He says we should honor the intent of those pushing for flawed alternatives to single payer, such as the ACA, but at the same time push for the goal of single payer and avoid a circular firing squad. Walter Tsao from Philadelphia was there. He's used to be the health commissioner of Philadelphia and president of the American APHA, American Public Health Association, a couple of years ago. So he says that state single payer in Pennsylvania faces stiff resistance from the Republican legislatures. Their bill is paid with 3% personal income tax and a 10% payroll tax. He threw out the idea of one way to get care to the undocumented residents is to cover everybody who files an income tax paper. Everybody gets a personal tax ID, everybody pays, and everybody benefits. So everybody who has, pays taxes gets covered. Wendell Potter was there. I think most of you folks know him. He's the whistleblower from Cigna, who created quite a stir when he, whistle blew on all the nefarious things they were doing to dump high-risk people. And he's been closely associated with the effort to get business into the single-payer camp. So he was there, and he talked about his new organization called tarbell.org, which does investigative journalism and does podcasts, and he'd be very happy for you to sign up to get this podcast. Chuck Panaccio, the guy behind One Payer States, was zoomed in from Philadelphia, and he talked about a few things. They have conference calls the third Friday of every month at 8 a.m. our time, and he'd be interested to have people tune into that call, which people working on state plans from around the country are a part of that organization. He says there's myths out there that we should fight competition is useful in healthcare financing, That myth has to end. We have to save that. There's a myth that we save money by restricting health care. What we end up with is worse and more expensive care, so on. New York, the executive director of the PNHP New York Metro chapter was there, Bob Lederer. He says that New York is the most exciting place in the country now for advancing single-payer legislation. They have a bill called the New York Health Act. Since 2014, it's been supported by a large coalition, including PNHP, the nurses, and other groups, including former Sanders campaigners, DSA organizers, and so on. The New York Assembly passed single-payer legislation 4 times with a 2-to-1 ratio, but it couldn't get voted in the Senate. But since the midterm elections, there's several more Democratic senators there, so the prospects of passing it are the best anywhere. He mentioned that if it passes, people are going to have to lean on Cuomo, and they're gearing up to do that. The insurers and the pharmaceuticals are creating a coalition to fight that movement advancing, and their coalition is called the Realities of Single Payer Coalition, and they're getting corporate money. Unfortunately, firefighters and cops and some other unions are opposed to the bill and are supporting the corporations, thinking that what they have now is better than what they may see under a state universal plan. So there's political work that needs to be done there. It says New York is considering applying for a public-based Medicare Advantage plan. Mike Huntington said that Oregon has had some talk about that as well. Just to end it, there was a lot of enthusiasm amongst those 23 people, and we talked to a couple of people at PNHP National asking them to have they've just redone the whole website, but to have a page focused on state single payer organizing. I thought maybe a national map where you can click on each state would be a good place for people to update what's going on in their state and communicate amongst those people that were there Friday and others that weren't there, to keep up to date and help each other push these efforts along. Dana?
Yeah, since PNHP was instrumental in crafting the original HR 676, has Pramila committed to consulting PNHP with any substantial changes that she wants to propose?
Well, she's meeting with a bunch of people. She's met with Adam Gaffney in D.C., I think once or twice. She's met with National Nurses United. I think she's keeping a lot of it under wraps at this point in time. There are other members of the Medicare for All coalition that have their own bills that are really not single-payer Medicare for All, that she's got to do some education around. So that's a work in progress. She did also form a single-payer PAC to raise money that helped elect some of the people in the recent election that supported single-payer.
On the Saturday morning plenary sessions, the first is a big series of slides that Himmelhandler do as a team that bring together all kinds of statistics of how things are doing. And it's important to have it, but I must say that I did not remember any of it. They are available on the website. By the way, if any of you are trying to access something on the website, discover that you need a password of some kind. The password is always the name of the current president of PNHP. The lunch speaker, it was unfortunate. The speaker obviously knows a great deal about the issue of mass incarceration of people with serious mental illness and how that is leading to too many people in jail and not enough treatment for mental illness. And he went whizzing through a bunch of slides and was reading from some kind of a paper, so his presentation was kind of a mess. And I noticed that his slides are not included, which is too bad, because I think it's something he's intending to publish, or he's working with somebody else, so it's not it's kind of embargoed, and therefore it can't go we can't get at it. But I think the big take-home message is that this is a whole huge issue that affects us in its effects, having large numbers of mentally ill people in jail. And then we went into the panels. And the first session had 5 panels. The first one on the list is reproductive health, which I went to. It gave some, first of all, abortion is the most common medical procedure done for women, which startled me. I didn't know there was that much. A bunch of myths need to be debunked. About 50% of unintended pregnancies end in abortion, and they've been decreasing. The number of unintended pregnancies is going down in the U.S., and that coincided with the end of abstinence-only sex education. In Colorado, they made long-acting reversible contraception available to everybody who needed it. And the decrease in unintended pregnancies, especially among teenagers, was abrupt and large. They also point out that unintended pregnancies lead to higher level of domestic abuse, decreased use of prenatal care, and increased poor result of pregnancy and infant care. And in other words, care of the infant once it's here. And I see that as part of the reason why our maternal death statistics are among the worst in the world, in the developed world, etc. We talked some about the Hyde Amendment, which keeps getting passed each year, that prevents spending any federal money on abortions. Some states use state funds to fill the gap, others don't. And now, of course, federally, they're proposing to change rules under Title X that will make it more difficult for clinics that provide both women's health care and separation with abortion providers, but in the same facility, that they will now have to be not only financially separate, but also physically separate, which is going to cause a problem. And they will even proposed rules might even prohibit referring anybody for an abortion. And they're going to have funds for faith-based fertility awareness and abstinence for contraception, which we all know does not work very well. And that requirement may be extended to federally qualified health clinics or health centers. And then they talked about how some states are hostile to abortion but that about 50% have no restrictions at all. And then they talked a bit about if Roe versus Wade is overturned, about 16 states will immediately ban abortions. 9 states have vowed to protect access to abortion. Title X changes, 36% currently get birth control through Planned Parenthood, and which is funded by Title X. So an important thing that's in the Senate Bill 1804 is getting rid of the Hyde Amendment. 1/3 of Americans are unaware that federal funds are not used for abortion. They also point out that the average cost for prenatal care, birth, and 5 years of raising a child, or 5 years of a child's medical care, is $17,000. So it's costly for people to have an unintended pregnancy go through. So questions that remain: can we get to full Medicare for all coverage for reproductive care? And how can we get stronger? The next one, Shamil, treating over-treatment.
Sure. So there was a large presentation for this that ultimately turned into going over maybe 2 slides and then just a large discussion amongst the 20 or so people that were in there. So it was really tough to keep track of, but some of the big points were ultimately they want to evaluate high technology waste and high value service. And some of the things they were discussing were end-of-life care. So they discussed how over-treatment during end-of-life care is incredibly expensive and for a non-PCOA perhaps prolongs dying. One of the things they discussed was how with having a single-payer system, it would allow for us to have more primary care-driven focus or emphasis. And with that, over time, you'd have more trust between patients and physicians, and then hopefully that would also reduce the amount of specialists that are needed for end-of-life care, so driving costs down. With that, you would also have more incentive to have preventative care and also early conversations for end-of-life care. It's not something that just happens very abruptly and often too late. One thing that they mentioned is actually a little counterintuitive, is how the NIH often looks for innovation instead of improvement, or in this case, quality improvement. So a lot of countries around the world focus on ways that they can improve their delivery of care and their efficiency of care. And if we went towards more of a single-payer system, then that might be something that, from a federal level, at least for overall costs, we would look to reduce costs via having more efficient, improving the quality of delivery. Another big topic was lack of interoperability. Basically, there's too many EHRs and none of them link up well enough. So a lot of testing that is redundant or done multiple times that doesn't get passed along to different providers for a given patient. And then they discussed global budgets and then a lot of arguing for about 15 or 20 minutes.
And I don't know if I can explain what I'm trying to ask very well, but end-of-life care is sometimes deliberate or planned and sometimes not planned. Mm-hmm. And it would seem to me that planned end-of-life care, someone who clearly expressed that they don't want to keep living when they're getting worse. One thing, others, when something happens, changes everything, it's end of life, not deliberate. Is that something that's discussed? I mean, I would think the latter would be more costly because people are trying to correct mistakes or bad decisions, but that's costly. I don't know how to explain it.
I think I kind of get what you're asking. One of the biggest things that they've talked about, at least trying to tie it into the overall talk, was often there's not a tremendous amount of primary care interaction with a given patient. So with that lack of trust and also lack of time for that discussion to happen. So it's usually a mad scramble right at the very end for the patient. So at least with having a single payer system and having more time spent with a patient and physician, the physician would have a better idea of what the patient may want. And also the family would have a better idea of what the physician's intentions are.
I'm not quite sure why a single payer would lead to better discussions between the primary care physician and the patient.
I wasn't quite sure on that either. That was just a premise that they had.
The only thing I can add to this is a specific case that I heard about today while I was playing bridge. One of the women that I played against, known her for years, she used to play with her mother, who got well into her 90s but has now died, as we were talking a little bit about how she must miss her mother, etc. And then she said that her mother was doing okay, sharpest attack, and then crumpled and fell. She had fractures in her back and also a fracture on a leg somewhere, something, an extremity fracture. So she's in the hospital, and the neurosurgeon is talking to her about whether or not to operate on this woman in her 90s, and asked the family and the patient, how active have you been? And they said, oh, she's been an absolute crackerjack. She's playing bridge, she's going around, she's quite independent. Although she's been using a cane and a walker and things like that for balance and so forth. And he said, okay, then we will operate. And they did operate, and she had 2 operations on her back and another one somewhere else. And ultimately, she sort of recovered from that and then kind of fell backwards during the recuperation and rehab and died. Not immediately, but it was the beginning of the end. So it's the kind of thing that, looking back on it, we can say maybe she shouldn't have had the surgery, but I was impressed to hear that going into it, the neurosurgeon had taken the time to find out what kind of shape this woman was in before deciding whether or not to do the surgery. So it's just an example, I think, of what we're looking for, that we, in terms of decreasing overtreatment, is stopping to think about things, especially towards the end of life.
That's what I think of. I don't know that I discussed with my primary care physician what I want. So I need to do that as a physician. I should realize.
Yes, Don. Yeah, right, exactly.
I think another large emphasis was in a single-payer system, at least when it came to improvements and saving money on more expensive tests, would be a larger emphasis on preventative care and maintenance,
Yeah.
which I think would also be more time.
Yeah, Shamil, I also wanted to ask, did they discuss hospice care at all during these your breakout?
It got brought up for about a minute, and then people started arguing, and they quickly changed the subject. So
Yeah.
they tried.
Yeah, because that's something that, with end-of-term care or long-term care is something that, working as a caregiver, when I did, that was something that we actually really valued because they're individuals who are geared for those hard questions, those hard discussions, as opposed to, the perception that I get sometimes when you treat a patient is like, what can I do for you, right? How can I treat you, as opposed to how can I, improve your life or your course.
Absolutely. The only thing that they really did briefly discuss was how we have a tremendous shortage, and they were very concerned.
Mm-hmm.
That was about as far as it went.
Okay, so John, you want to go next with physician burnout?
Yeah, so the breakout session that I attended was with Gordy Schiff, one of the founders of PNHP, and it was on physician burnout. And initially, some interesting statistics that were brought up were that in a survey done, at least 54% of physicians surveyed have at least one symptom of physician burnout. And there are three primary symptoms that you look for with physician burnout, and that is emotional fatigue, depersonalization, and a low personal accomplishment, or a low perception of one's accomplishment. Something that was brought up that I thought was really interesting is that in a survey done in Alberta, in Canada, with a country that has a single-payer system, approximately half of physicians in Alberta are in some phase of physician burnout. And so that kind of makes us think critically about whether or not a single-payer system can address some of the issues that we see with physician burnout. And, we had some interesting discussions around that. So we emphasize that, we may be seeing physician burnout, but at least they have less administrative work that they have to deal with. Yeah, did you have a question?
Yeah, did they discuss why these physicians in Alberta had high rates of burnout? Was there a reason?
Yeah, so the question was why there were high rates of physician burnout in Alberta, and that really wasn't discussed as much, though it's something that we had a few ideas about, but there was really nothing that we could settle on that pointed towards high physician burnout rates. Yeah, some other interesting statistics that we saw was that between the different races, Black physicians actually have lower rates of physician burnouts at approximately 48%, whereas Chinese and white physicians have higher rates. One of the reasons that we might still be seeing high rates of physician burnout is because of the added stress of managing cost when determining a patient's course. One thing that Gordy wanted to emphasize is that under a single payer system, he believes that it would allow the physician to not have to worry so much on the bad components of patient care, whether that's whether or not they can have access to care, or if they have to deal with electronic medical records, and that would free up the physician to focus more on the good aspects of their patient treatment and be able to build a better relationship with them and free them up to spend more time with their patient. We also had a really interesting discussion on how physicians can be involved with advocacy and how that could potentially play into battling some of the symptoms of physician burnout. But somebody else in the discussion mentioned that could also add to the stress and the burden that physicians face, because it's just more time spent doing activism or advocacy work and policy work like we do here. And so we had further interesting discussions about that. And then one final point that I wanted to make that was brought up was that in the traditional macho versus martyr culture of the physician, it's somebody noted that there's really not a whole lot of room for self-care in a system like that, which I thought was interesting.
This is the new 2018 updated Wool Handler and Helmstein massive slide collection. Now, this isn't meant to be presented at a grand rounds, but within this, there's 10 or 15 topics that each has 6 or 8 or 10 slides associated with them. So there's 2 ways to use this. One is just to go through it yourself, because you'll learn a whole lot just by looking at these slides. And each slide has a reference, so if you want to see where the information came from, you can do that pretty easily. So I just wanted to show you here, basically, this is the slide set, 200, there's a long slide set and a short slide set. So this is the long one. And I'll just bring up a couple here. Okay, basically, this is what they look like. The last ones here are talking about the differences between 1804 and 676, concerns about it. So beware of the sound-alikes. Basically, usually there's some sort of public option which is within the current marketplace, so it doesn't transform our system. It just makes some changes to the outside of it, nibbles around the edges. Okay, so I went to a workshop, Policy Pitfalls. Starts off with how the support for single-payer national Medicare for all is increasing. And this is a recent poll, Reuters poll, showing overall 70% of people support Medicare for all. That covers everybody at one single public plan. And that includes 84% of the Democrats and actually more than 50% of the Republicans. So Obama even, I didn't follow this link, but apparently in September he made a positive statement about single payer for the future. So there's various ways of describing these Medicare for all plans that are not based on HR 676, and some people call them scam Medicare for all, Faux, Medicare for all, fake Medicare for all. So anyway, this most of this workshop was looking at those other plans that people get confused with, because
well, you did a lot with our handout, right? We have a handout that has a good comparison of them all.
Yeah, there's a couple of them.
Yeah.
But if you look at the polls, people say, yeah, I love Medicare for all, 70-some% of the general population. But do they know what Medicare for all are they thinking about? Because their particular politician may be introducing one in Congress that's quite a bit different than HR 676. So there's a lot of education that needs to go on to guide people towards Medicare for all. That's single payer, everybody in, nobody out, no co-pays, and no tiered system where the rich people get better care than the poor people. So these are the variants that you have seen out there in the last year or so. Public option and the ACA marketplaces, and I think maybe that bridge bill that Nicole Macri was talking about for healthcare for all Washington, that's going to be introduced in the Washington State Legislature, is going to have some kind of public option within the marketplace. Anything to say about that, Sherry?
Well, it's going to be specifically with an intent to move on to full single payer by 2023. And this is to take care of the group that's hurting the most right now. Yes, it is sort of a public option right now, but it's also putting in place some of the administrative things, that building blocks that would be needed to actually run a single payer system starting in 2023. So it's a little more hopeful than these, which are these standard public options that are intended to sort of throw a bone at people and then call it quits.
Some of the public options, the Medicaid buy-in, Idaho or Colorado, the governor there a year or so ago was thinking that this was a good idea. So people could use their ACA subsidies to buy into Medicaid. However, that would raise Medicaid rates to Medicare levels. So there's Medicare buy-in bills. There's a couple of them out there that have been introduced. Medicare Extra for all. You can get this slideshow and go through it slowly at your leisure to see exactly what these differences are by a link that we'll put on our website that goes to this link, which is on the PNHP national website. So legislative shortfalls this is looking at 676 and 1804. So basically, the main thing is to keep incentive-based payments out of there, keep global budgets in, which 676 does, and keep for-profit providers out of the system, what 676 does, but 1804 doesn't at this point.
There were 6 workshops in the afternoon, and let's start with Shamil, attacks on the VA. Oh, go on.
I can speak loudly if needed. So this was hosted by Suzanne Gordon. The first half was really just a brief discussion of the VA itself. So largest healthcare system in the country, only publicly funded healthcare system in the United States. The biggest take-home point from her was that people who are fighting for a single-payer system should definitely buy in on fighting to prevent privatization of the VA, for the simple fact of that's the closest model we have to a single-payer system, or I guess is the model currently. And some of the benefits she talked about, I'm actually looking forward to this as a future military doc. You work on a salary, so there's no real incentives for you to overtreat. You have lifetime responsibility for your patients. You'll be seeing similar people in similar areas consistently. Huge patient population, which is consistent over time. Your patient panel is about 1,100 people instead of the 2,000 plus that it can quickly ramp its way up to. A couple things that they mentioned. She briefly talked about some of the acts that are being pushed through right now to work towards privatizing the VA, and one of the big ones was the Mission Act. My understanding of it is that it allowed for people, vets who are part of the VA system, to use non-VA hospitals. So basically, if you have to travel over 30 miles to a VA hospital, you can go to another public option, which will ultimately take VA usage and drive it to the floor. So a ton of people are using VA hospitals. You won't need to fund it as much. If you start reducing that amount of money, you ultimately can shred the system. So that was my general understanding of the Mission Act. And the rest of that discussion, she has a book coming out that she made very clear was on sale. But ultimately, basically, she wanted us to, the biggest push forward is work towards making sure the VA is not being privatized and keeping track of acts such as the Mission Act, which will intentionally defund the whole system.
John, you want to tell us about the one you went to, which is Medicare for All in the House and Senate?
So this session was really interesting and very, very lively at times, with actually some arguments breaking out. It was in a small room, and it was standing room only, and so there was lots of energy in this session. It was led by Ian Kemp at Public Citizen, as well as Alex Lawson at Social Security Works, who are both big proponents of single-payer healthcare, and moreover, they just had very, very deep insight about the whole legislative process, about what strategies that we need to implement in order to get these bills through committee, through House, as well as through Senate, and ultimately to the President's desk. So yeah, something that we discussed, that we tried to emphasize with some people who are very pessimistic in the room, was that PNHP is actually involved with some of these changes that Pramila Jayapal is making to HR 676. There was lots of worry by the rest of the PNHP chapters about the changes that are being made, because the original bill was, as David said, made by PNHP. And so something that I brought up, that we were meeting with Pramila Jayapal and stressing some of these policy shortfalls, and some of these the shortfalls of the changes that she was proposing, and other components that we wanted to make sure that she included in HR 676 revisions. Yeah, it was interesting, because here in Washington State, we were in an interesting position, because we have Pramila Jayapal as the head of the Medicare for All caucus, and then we also have Senator Patty Murray, who in the Senate is a ranking member of the Health, Education, Labor, and Pension Appropriations Committee. And she's also a ranking member in subcommittee on Health and Human Services and Education. And so in some of our discussions, one thing that the speakers emphasized was that if this bill has if any of these committees in the House or Senate has any jurisdiction over this bill, they can take that bill into their committee and make revisions to it, which is why what they wanted to stress with us is that we need to build a really broad social movement with wide support and educate as many people as possible on single-payer Medicare for all, and also some of these sort of dangers to any revisions to these bills that might be imposed and create these faux single-payer bills. Yeah, like I said, it was a really lively discussion. One thing that they brought up that I actually didn't realize was that HR 676 is actually a draft bill. It's not legislation yet. And so what they warned is that in the process of taking HR 676 and writing it into actual legislation, a lot of changes can actually be integrated into the bill in that process as well. And that's why they kind of understood and agreed with Pramila Jayapal about using 1804 as a template single-payer bill, because 1804 is actual legislation and can be signed into law much sooner than HR 676. So I found that to be really interesting, and those are the main takeaways that I had from that session. The rest of it was pretty much just bickering and arguing and pessimism, which was not very productive.
Chris Wong was at that meeting too. I just wanted to add, it was striking to see some, I think, long-standing PNHP members really pretty jaded about the whole thing, saying that they're not good, politicians aren't doing anything, and having these lobbyists actually excited that it might actually work. And their big thing, I think, was getting the right people on Ways and Means. That was my other big takeaway from that. It's getting the right legislators on the Ways and Means Committee, which is not there yet, and so there's still nothing that's going to happen until that happens.
And somebody also asked about PNHP getting lobbyists themselves. Do you remember what was said?
Yeah.
Yeah, that was extremely interesting. So I think it came up in one other workshop also, but whether PNHP should have a lobbyist. We have other huge physician organizations that have lobbyists, but they're obviously not on board. But whether we should, and I think the point was made that PNHP is member-driven and members kind of do their own thing as individuals, not necessarily as a big lobbying group. So, but there's no conclusion.
Yeah.
A lot of people frustrated at previous blood letters.
Okay, I went to a workshop that was called "What Went Wrong with Healthcare: Commercialization, Managerialism, and Corruption." I brought the slideshow, but we're not, it's 2 minutes to 9. But I want to encourage all of you to go and look at it. It was put together by Dr. Roy Poses, who has been very active in bringing to light the corruption of the profession of medicine that's been going on for some time now. And that really is the underlying theme of this. So it's both historical in that it indicates what has happened to transform our healthcare system into this giant medical industrial complex that we're all living with now. And it's difficult to unwind because it's so huge and it has so much money. But it also has pointed out the results that we get poor government with large corporations running medicine. We get poor governance, poor leadership, leading to intimidation and deception, leading to threats to core values of physicians and threats to evidence-based medicine. And so we're dealing now with government bumbling and corporate intentional rip-offs. And together they are screwing up the system. Professional ethics has gone in the direction of laissez-faire and Gilded Age robber baron behavior. I really encourage you to go on the website and browse through the slides. There are 70 slides, so it takes a while, but it will help solidify in your mind things that we all kind of know about. And if we don't know about it and understand how we got here and where and why all the power is, we aren't going to be able to be very successful in changing it. So I would think that in a nutshell is this workshop, which opens up a whole another area. Okay, and David, I left you till last because
you'd given me a couple minutes, so I think I just talked to you about what happened at the board meeting on Sunday.
Oh, yeah.
Most of you weren't there. First of all, just the membership of PNHP is 22,683. That's an increase of 700 since last year. About 65% of the members are physicians, 5% students, and about 20% are current with their dues. So basically, once you become a member of PNHP, you're in it for life. The only way to get it out is by dying or renouncing it. And I think there's been one or two people that have renounced it over the years. The focus needs to be on reaching out, bringing in new members, contacting lapsed members, and asking them to become more active during this time, which is looking good for single payer being on the rise. Our chapter here in Western Washington has the third largest amount of fund reserves that the national office is holding for us. So we got plenty of money for what we're doing, except we don't have an office manager or a lobbyist. The board welcomed Adam Gaffney, who was elected obviously unanimously to be the president of PNHP for the next 2 years starting in January. I talked to Adam and he's definitely interested in coming out here. He's wanting to travel around. He says he will have some time available, so if we'd like to invite him out for a meeting, he'd be very happy to come. And also I noted there's some organizers on the staff there. A couple of them gave some talks that were really quite good and really nice speakers. So we could have maybe one of those organizers come out, student age, and talk to the SNAP chapter, perhaps. They talked about the pros and cons of PNHP being a 501c4 organization.
Powering off.
The pros and cons of hiring a DC-based lobbyist.
Powering on.
They talked quite a bit, for a few minutes about that. And it sounded like the board would be the executive board would be talking more about that later, perhaps sharing a lobbyist, but now's the time to do effective lobbying before HR 676 is finalized. Talk quite a bit about how to reach out to physicians and forming coalitions with other organizations, Medicare for All Forward. I think there was consensus there. Don McCann, a few weeks ago said we should be calling this single payer Medicare for All to differentiate it from all the other plans that are called Medicare for All that aren't single payer. So maybe we should start using single payer Medicare for All. Talked about Milla's considering changes in 676 to become more like Sanders' bill, and there's a lot of concern expressed about that throughout the weekend. But he has met with her, and he thinks that she's quite good on value-based payments being not a good idea, and global budgets. He's unclear at this point on how she stands on retention of for-profits, which are in Bernie's bill. But I've talked to her about she's definitely against getting the profit motive out of medicine, but she's a politician and she may have to triangulate to move things forward. So, but I'm hoping that for-profit providers are not within the bill. And also, PNHP put together a draft letter that they were going to talk, that talks about 676 and S1804. I saw a copy of that and was hoping that they were going to, the idea was to send that to Pramila before our group in Washington State met with her, give her a heads up on what was going to be done with this letter, which was they're thinking about sending it to all co-sponsors of 676 and people in the Medicaid Care for All caucus, and then perhaps having it become a sign-on letter for people like us and other organizations to sign on to and to send to all of our representatives in Congress. So I think there's going to be work done about that, and I think probably within the next month or so we'll see a sign-on letter coming out. One more thing, I heard a couple of comments saying that state-based organizing is probably one of the main reasons that single payer is becoming much more within the public consciousness, and the reason that these polls being more and more in favor of single payer, that organizing being done at the state level, even though it may be a state level plan is turning on the consciousness of people. And all of these state plans are also saying people should put pressure on their congressional representatives to support single payer at the national level.
Yeah, I just wanted to point out that this doesn't seem to be live. I turned it, oh, there, I didn't push it all the way. If you're going to get out, the for-profit stuff is now gigantic. And in order to get rid of it, we're going to have to find a way to kind of buy them out. And that's going to mean, the most likely is going to mean a bond issue that will be pay them up front, but the bond issue itself will be paid off over time. But then that's a way that you can do it, because you can't just pull the rug out from under and 1/6 of the nation's economy without, and that's an exaggeration because not all of that 1/6 is for profit, but you still are going to need to do something because it's so huge as compared with when Canada put theirs in place during the 60s through 80s. They didn't have anything like the amount of money invested in the system as an investment for profit.
Well, this latest health affairs article that I passed out today, Immelstein, and we'll have to look exactly at that issue, how much it would cost to buy out all the for-profits. And to me, it was surprisingly a small amount. And as Jerry said, they figured out how buying government bonds to pay for it and paying them off over 15 years at 3% or whatever the current bond rate is would be much more cost effective than continuing with the for-profits as they are now.
So it would be about 150 billion over 10 years. That's what I recall.
150 billion over 10 years. It sounds terrible, but anyway.
That sounds like such, Jeff Bezos is worth that.
Right, that's true. Okay, we have run over time and we did manage to fill it all, and this is the end of the meeting.
Can I say just one thing very quickly?
Absolutely.
Great. I had the pleasure of attending a demonstration at Pramilla's office this afternoon on behalf of the Sunrise Movement, which is youth-led and going across the nation, supporting the Green New Deal, which is being put forth by Ocasio-Cortez. It includes healthcare for all. I really encourage you, if you haven't already, to get in touch with her, find out more about the resolution so that you can be collaborating on this. I don't want you all going in different directions, because we want whatever they come up with to include the work that you've been doing.
Sounds great. Thank you.